Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 493 of our pharmacotherapy series, which majors in acute kidney injury. TBM is an 18-year-old white male college freshman, whose height is 5 feet, 8 inches. He weighs 150 pounds, and is in otherwise good health, who recently developed strep throat. He received a 10-day course of amoxicillin, which cleared the infection. He returns to the student health center after completing his 10-day course complaining of puffy eyes, swelling in his legs, a cough productive of clear sputum, and decreased urine output that appears tea-colored. Other than the amoxicillin, he is not on any medication. Baseline records from a routine physical examination 2 months ago reveal a BUN and serum creatinine of 10 and 0.8 milligrams per deciliter, respectively, and a blood pressure of 120 systolic 80 diastolic. Today, the physical examination is significant for a blood pressure of 176 systolic 95 diastolic, 2 plus peripheral edema, and bilateral pulmonary rales. The urinalysis is significant for gross hematuria, nephritic range proteinuria, RBC and WBC casts, and epithelial cells. TBM's serum creatinine has increased to 7.1 milligrams per deciliter. Based on the history, physical examination, and laboratory findings, what is the most likely cause of acute kidney injury in this patient? TBM's recent history of a streptococcal infection with the development of acute kidney injury suggests post-streptococcal glomerulonephritis, which results from the formation of antibodies against streptococcal antigens. The streptococcal antigen immune complexes are deposited in the glomerulus, resulting in complement, cytokine, and clotting cascade activation. Neutrophils and monocytes attack the glomerulus, causing glomerulonephritis. The onset of post-streptococcal glomerulonephritis is usually 7 to 21 days after the start of the pharyngeal infection. Post-streptococcal glomerulonephritis is the most common acute onset, immune-mediated, diffuse glomerulopathy. It primarily affects children, although it can affect any age group and is more prevalent in males than in females. Certain serologic subtypes of group A beta hemolytic streptococci, known as nephritogenic strains, cause post-streptococcal glomerulonephritis. The M and T proteins located in the bacterial cell wall are used to classify streptococci. Nephritogenicity has been shown with certain M serotypes, e.g., 1, 2, 4, 12, 18, 25, 49, 55, 57, and 60. Strains that follow pharyngeal infections, e.g., strep throat, include types 1, 3, 4, 6, 12, 25, and 49. Type 49 is the most prevalent strain worldwide. The overall risk of developing post-streptococcal glomerulonephritis by the M-type 49 subtype when present in the throat is about 5% and increases to 25% if it is found in the skin. Acute post-streptococcal glomerulonephritis has also been described after infection with group C streptococci in epidemics outside of the United States. Positive diagnosis of post-streptococcal glomerulonephritis requires identification of a nephritogenec strain, objective urinalysis findings suggestive of glomerular damage, such as proteinuria, hematuria, and casts, and elevated streptococcal antibody titers. TBM exhibits the classic physical and laboratory findings associated with post-streptococcal glomerulonephritis. The pertinent positive physical findings include periorbital, pulmonary, and peripheral edema, tea-colored urine, hypertension, and decreased urine output. Edema is a common manifestation, with periorbital edema typically being the first to appear. Reduced glomerular filtration rate, proteinuria, and sodium retention by the kidney all contribute to edema formation. When protein, principally albumin, is lost in the urine, the intravascular oncotic pressure declines, causing a shift of fluid into the extravascular space. The loss of intravascular volume stimulates sodium and water reabsorption by the kidney via aldosterone and vasopressin, which often produces stage 1 to 2 hypertension. Pertinent laboratory data in TBM include elevated serum creatinine, and urinalysis positive for hematuria, proteinuria, WBC casts, and epithelial cells. Hematuria, which is found in almost all patients with post-streptococcal glomerulonephritis, accounts for the reddish-brown, tea-colored urine. Other commonly found urine sediments include cellular casts and hyaline and granular casts. Oliguria is common in post-streptococcal glomerulonephritis, but anuria is rare. Given that TBM has received a 10-day course of amoxicillin, it is unlikely that throat cultures for the nephritogenec group a hemolytic streptococcal strain will be positive. Cultures of close contacts may, however, be positive for the streptococcal strain, even if they are asymptomatic. The presence of circulating antibodies to the nephritogenec streptococcal strains indicates recent exposure. The antistreptolysin O, abbreviated as ASO, antihyaluronidase, abbreviated as AHAs, antideoxyribonuclease B, abbreviated as ADNES-B, and antinicotyladenine denucleotidase, abbreviated as NADES, antibody titers can be measured clinically. Antistreptolysin O titers begin to rise 2 weeks after pharyngeal infection, peak at 4 weeks, and slowly decline over the course of 1 to 6 months. No correlation exists between degree of antistreptolysin O rise and nephrogenicity. In fact, antistreptolysin O titers may not be elevated at all if early antibiotic treatment is initiated or in cases of streptococcal skin infections. The use of antideoxyribonuclease and antihyaluronidase titers is more specific to detect recent infection in these situations. My next question to you reads: are there other tests that can be used to confirm this diagnosis? The streptozyme test, which can be used clinically for rapid screening purposes, uses several antistreptococcal antibody assays. False positive and false negative results are common. However, because of cross-reactivity between the antibody and normal collagen. Serial complement determinations may be of value in diagnosing post-streptococcal glomerulonephritis. Decreased levels of C3 protein and hemolytic complement activity are observed in nearly all patients with active post-streptococcal glomerulonephritis. Serum C3 levels can fall by nearly 50% of normal in the first weeks of infection and return to normal within 8 weeks after infection. No correlation, however, exists between the degree of C3 depression and severity of nephritis. Circulating antibody complexes of C3 can be found in patients with acute infection. Renal biopsy is rarely needed, but it may be prudent in patients who present with atypical symptoms, such as anuria, prolonged oliguria, marked azotemia, hematuria for more than 3 weeks, or in those who have no streptococcal antibody titers. My next question to you reads: what are the therapeutic goals and treatment options for post-streptococcal glomerulonephritis? The therapeutic goals are to minimize further kidney damage and to provide symptomatic relief for TBM. The underlying streptococcal infection should be treated with appropriate antibiotics, but as illustrated by TBM, this has no effect in preventing post-streptococcal glomerulonephritis. Family members and close contacts of the infected patient should receive antibiotic prophylaxis as well. Restriction of protein to 0.8 gram per kilogram per day may be beneficial in patients with marked proteinuria, and antihypertensive drugs can be used on a short-term basis to control blood pressure. Sodium and water restriction is beneficial in reducing edema, and loop diuretics may be used as needed for symptomatic pulmonary or peripheral edema. Close monitoring of electrolytes is warranted if diuretics are used. Dialysis is rarely required. Given his age and previous health, TBM's prognosis is very good. In general, prognosis is excellent in youth, but significantly worse in the elderly and in patients with other risk factors for chronic kidney disease, such as diabetes mellitus and hypertension. My next question to you reads: are there other glomerulopathies that cause acute kidney injury? The correct response is yes. Rapidly progressive glomerulonephritis, abbreviated as RPGN, also called crescentic glomerulonephritis, is a clinical syndrome of rapid decline in renal function, from days to weeks, combined with the hallmark findings of gross hematuria, nephritic syndrome with proteinuria, and the presence of extensive glomerular crescents, that is greater than 50% of glomeruli, on renal biopsy. It is not uncommon for patients with rapidly progressive glomerulonephritis to have a 50% decline in glomerular filtration rate in only a few weeks. Rapidly progressive glomerulonephritis is a medical emergency, and treatment success depends on how early therapy is initiated. If left untreated, progression to end-stage renal disease or death is almost certain. Idiopathic rapidly progressive glomerulonephritis is divided into 3 categories based on immunofluorescence microscopy. Type 1 idiopathic rapidly progressive glomerulonephritis is characterized by linear deposition of immunoglobulins, primarily IgG, along the glomerular basement membrane, abbreviated as GBM, indicating anti-glomerular basement membrane antibodies. Type 2 idiopathic rapidly progressive glomerulonephritis is identified by granular immunoglobulin and complement depositions in the glomerular microvasculature and mesangium, suggesting immune complex deposition. Type 3 idiopathic rapidly progressive glomerulonephritis is also called quasi-immune because there are no hallmark immunoglobulin or complement findings on immunofluorescence microscopy. Type 3 idiopathic rapidly progressive glomerulonephritis is identified by the presence of circulating antineutrophil cytoplasmic antibodies, abbreviated as ANCA. Type 4, known as double antibody disease, is characterized by antiglomerular basement membrane antibodies and antineutrophil cytoplasmic antibodies seen in types 1 and 3 rapidly progressive glomerulonephritis. Multisystem vasculitic disorders that result in glomerular capillary inflammation are the most common cause of rapidly progressive glomerulonephritis. Many of these patients present with nonspecific FLU-like symptoms such as fever, weight loss, myalgia, and malaise with proteinuria and hematuria. Uremic symptoms can occur with severe disease. The presence of acute kidney injury with pulmonary congestion, cough, hemoptysis, or dyspnea suggests Wegener's granulomatosis. The treatment for autoimmune rapidly progressive glomerulonephritis generally involves various regimens of immunosuppressive agents. Corticosteroid monotherapy, oral or pulse, intravenous, or combined with either cyclophosphamide or rituximab have been investigated. Rituximab may improve renal outcomes in type 3 idiopathic rapidly progressive glomerulonephritis. In addition to anti-B cell therapy, therapy directed at T cells may improve renal outcome. Plasmapheresis is also a non-pharmacological treatment option in selected patients. My next question to you reads: which drugs cause glomerulonephropathy? Minimal change disease and membranous nephropathy have been associated with non-steroidal anti-inflammatory drug use. The mechanism is probably related to non-steroidal anti-inflammatory drug-induced inhibition of the cyclooxygenase pathway, which leads to increased arachidonate catabolism and increased pro-inflammatory leukotriene production. The hallmark feature of non-steroidal anti-inflammatory drug-induced nephropathy is nephrotic range proteinuria. The nephropathy resolves slowly over the course of several months once the non-steroidal anti-inflammatory drug is discontinued. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 494.